CataractCoach.com, and someone asked me, what's your ideal case? Not a perfect case, but an ideal case for you. Very typical for your practice. And I said, well, this is one of them. Let me show you. So it's a routine patient, going to have cataract surgery. Pupil dilation is reasonable. Patient does take Flomax, but still dilates pretty well. We're putting in our dispersive viscoelastic here. I do like a nice coating of the endothelium, a big wave coming across. If it fills up with spaghetti string, it doesn't coat the endothelium well. A big wave really coats it well. Incision, I do like a single plane temporal incision, appropriate tunnel length, just about like that. That looks great. Now you can use a diamond keratome, which is normal for me in Beverly Hills. And sometimes like this, we'll use a steel keratome. There's measuring in my mind what would be the ideal capsulorhexis, using our forceps here to tear that. And we want, again, 5.5 millimeters. Now, this idea of having your ideal case is important because it gives you something to shoot for. And every patient, like here, I want to make that round rhexis of the right size. I also want it really well centered in the patient's pupil and, of course, visual axis. And that looks great there. Now, when it comes to removing the lens nucleus, I want to really minimize the phaco energy, and I want to be away from the capsule. Nothing better than that than like this. Flip and chop. So we prolapse the nucleus partway out of the capsular bag. This is a typical kind of case we see in California. Just a moderate degree of nuclear sclerosis, not a very dense cataract. And now with the phaco probe, a very minimum amount of energy is going to be needed to remove this lens nucleus. We're just adjusting the phaco tip and putting the probe in the eye. Here comes our chopper. First thing is just hold the nucleus of the probe and just, boom, chop in half. Now each half can easily be emulsified. So here comes the first heminucleus. Then we'll do the second heminucleus. There's a little bit of an epinuclear shell we'll take out. And, just about 2.5 minutes into the case, we'll have the entire nucleus out of the eye. So it's a pretty efficient technique. It's very safe. We're far from the capsular bag. The endothelium is certainly protected with the viscoelastic. We're operating more at the iris plane. We're not up against the endothelium. We use phaco power modulation to limit the energy. Look at the chopper position to protect. Make sure if the capsular bag does come up, it never contacts the phaco tip. And all that stuff's very important. Looking at the rest of the case, look at the eyelashes and the lids. Nicely draped out of the way, not a single eyelash visible. None of that oil from the tear film is on top of the cornea. Cortex removal going around here, circumferential manner. This patient has a lot of cortex. We'll remove that. Careful, of course, to watch the capsulorhexis edge. Make sure that doesn't move. That would be a sign of weak or loose zonules. And now it's cleaned up pretty nicely. Tiny bits of wispy material. Remember, I'm emphasizing the red reflex in all the videos. So you may see some material here that really is not clinically significant. It's really minimal and it melts off in the inflammatory cascade within just a day or two. Single piece acrylic lens is certainly my fastball technique. This is my go-to. Lens going here, nicely delivered in the capsular bag. Choppers used for fixation to hold the eye through the paracentesis. And now we'll deliver that lens and make sure it goes completely in the capsular bag and let it unfold. I do like to rotate the lens so that it's about 12 and 6 o'clock so that I can get the optics centered beautifully in the visual axis. Definitely like to remove all the viscoelastic. If you leave viscoelastic in the eye, you're going to have a pressure spike on post-op day 1. And we certainly want to avoid that. So to avoid that, we're going to aspirate all the viscoelastic out from behind the lens, and obviously in front of the lens in the anterior chamber. People sometimes ask about my settings here on the light. Why is the red reflex so good? Look at the light reflex. Look at the Purkinje images. The two big lights that you see there, the twin lights, those are the red reflex lights. And the smaller lights, the normal lighting. So I preferentially adjust this to make good videos so that I can show you what's my ideal case. Little tiny wispy stuff of cortex, that's of no consequence. And that is my ideal case.